Hello, my name is Emily Hamilwright, and I will be reviewing Case Study 1. To begin my case study discussion, we will review the client. So this client's profile is a female at the clinic that I work at who is 4 years old. Their main communication modes include speech device and emitting vocal sounds with minimal functional speech output. Currently, they are receiving services from occupational therapists 2 hours a week and speech therapist 1 hour per week, with them coming 2 separate times throughout the week during clinical hours, as well as 40 hours a week of ABA services within the clinic. Their diagnosis is on autism spectrum disorder, and target behaviors include aggression, elopement, screaming, tantrum, flopping, and mouthing. The behavioral concerns and defined behaviors include aggression. Aggression could be biting, which is any instance or attempt in which the patient passes any part of another person's body past the plane of her lips or uses her teeth to press into their skin. Each removal counts as a new instance. Pinching, which is any instance or attempt in which the patient uses 2 or more fingers to grasp another person. Hair pulling, which is any instance or attempt in which patient uses her fingers to grab another person's hair and pull it in any direction away from their body. Pushing, which is any instance of patient placing her hands on a person and using force to move them. Elopement is any instance or attempt in which the patient moves more than 5 feet away from an adult without express permission to do so. This applies to any environment and regardless of the previous command. Screaming, which is any instance in which the patient vocalizes over the typical speaking level. Tantrum is any episode in which the patient begins vocalizing an ah sound over voice level with or without tears for more than 15 seconds. Can be accompanied by other behaviors and should be recorded in frequency with an inner response time of 30 seconds for each new episode. Flopping, which is any instance in which the patient suddenly drops or attempts to drop their body to the ground, or would have dropped to the ground if there wasn't an obstacle, an item, or a person. And mouthing, which is any instance or attempt in which the patient presses an object to her lips, passes an object or body part between the plane of her lips, or makes contact with her tongue to an object or body part. This does not include chewy, eating utensils, food, cup, or drink. Any removal of the item or tongue counts as a mark of a new instance. The assessments completed to address these behaviors of concern included a functional-based assessment with a direct assessment of ABC data collection, an indirect assessment of functional assessment interview with the primary caregivers, as well as the ABLS-R assessment. The FBA was the functional-based assessment, which the ABC data was collected over 1-hour sessions with 3 of the patient's regular therapists throughout a week's period. They conducted a functional assessment interview with a meeting with the primary caregiver and the BCBA present. Results of the FBA showed that hypothesized functions from ABC data collected was 28% escape maintained in function, 35% access maintained or function, 15% automatic function or maintained, and 22% maintained or function of attention. The primary functions of behavior include escape and access, with those having the highest of the hypothesized functions. And there is access to tangibles, which is behavior due to seeking access to preferred items previously denied or escape, and behaviors due to avoidance of non-preferred tasks or demand, as well as the ABC data. The indirect assessment with caregivers and the BCBA showed that primary concerns included behaviors occurring during non-preferred tasks or demands being placed, including toileting, putting on socks and shoes, and then with access to preferred items, denied access, and these pose safety concerns as well as various concerns with the parents that they wanted to address these behaviors so that there could be increased independence in toileting, so that there could be hopefully a transition to school and being able to follow demands and accept denied access to things, as well as increased ability for communication and social interaction. The findings of the ABLES-R assessment showed an overall score of 43. The results found that there were skills higher in areas of play and leisure and classroom routines, with the most deficits found within social interaction, group instruction, and generalized responding. So, reasoning for choosing an FBA and ABLES-R in order to address the behaviors of concerns and work on creating an IEP included the challenging behaviors that could interfere with assessments. So using an FBA where it's just observation and behaviors are able to occur naturally and do not interfere with that being a chosen assessment, as well as an indirect assessment method, helps to give us some information without those behaviors being a barrier to collecting the data, as well as ABLES being more on age appropriate, able to be done even with language delays, and fit for early learners, as well as helping to find what areas are have deficits or there's missing skills in order to create the intervention goals or the IEP. The FBA was able to help support understanding function, give insight from caregivers on what they want to address, what they find important, and what they are seeing in different settings, as well as the direct observation, giving a lot of insight into antecedents and consequences, as well as a better understanding of certain triggers of the functions of these behaviors. Task list items that related to this case study include C1, establish operational definitions of behaviors and establishing those definitions. C3, which is measuring occurrence of behavior, which was done throughout assessments. F1, review records and available data, which is done within the indirect assessment, as well as reviewing all the records throughout assessment periods and with caregivers and the BCBA. F2, determining the need for behavioral analytics services. F3, identify and prioritize socially significant behavior change goals based on, age, families, input, and socially significant behaviors that are seen to be a deficit currently. F6, describing common functions of problem behavior. F9, interpreting functional assessment data. And H8, making database decisions for needs of services. And to finish up, for planning interventions, the FBA was able to find replacement behaviors, address antecedent interventions, and be able to match the consequence of intervention to the functions of behaviors, as well as the ABLES are creating the IEP, the individualized plan, addressing the missing skills, and building upon the current skills that the patient already has.